Good afternoon, everyone. Thank you for joining the National Hispanic Council on Aging to discuss the impact of vaccine policy on health equity. My name is Yanira Cruz, and I am the President and CEO for the National Hispanic Council on Aging. NHCOA, as we typically call it, is an organization that of national in scope that works to improve the lives of Hispanic older adults, their families, and caregivers. I'm joined today by a fantastic group of advocates representing a vast population of diverse, multicultural communities, as well as our panel of experts who are working every day to advance health equity and equitable access to vaccines. And so today with us, we have Nandini Selvam. She is the president of IQVIA, Government Solutions. And of course, Karyne Jones is the president and CEO of the National Caucus and Center on Black Aging. Dr. Georges Benjamin, Executive Director of the American Public Health Association. Thank you all for joining us. And as we know, health equity is a multifaceted issue, and all of us here know the incredible power of vaccines to help protect ourselves, individuals, and communities. Unfortunately, this incredible power has not met its fullest potential. Today, particularly within the context of respiratory illness season, we come together to shine a spotlight on vaccine policies that can inadvertently create barriers to health equity within the United States, and most importantly, to explore potential solutions to help bridge this divide. And so we'll begin with a data presentation by Dr. Selvam, which will provide an overview of recent data on adult vaccination trends in the United States and ongoing disparities in vaccine uptakes. We will then move on to a moderated discussion with all of our speakers. Our panelists will cover a range of topics, including recommendations for broadening equitable access to vaccines that protect against infectious respiratory diseases and the role that vaccines play in public health. And so before that, though, before moving forward, a few housekeeping notes before we get started. First, we encourage you to ask questions following the data presentation or during the discussion afterwards by using the Q&A chat function. To submit a question, click on the Q&A icon on your taskbar at the bottom of the screen. We should also note that we will be recording today's session as we plan to make it available on our website for future days. And again, I'd like to express my gratitude for joining us today, for being here. I look forward to the insights from our speakers and thought-provoking questions from the audience. So now I am pleased to introduce Nandini Selvam. She is the president of IQVIA Government Solutions. Nandini is an experienced epidemiologist with a background working across vaccines and infectious and chronic diseases. Nandini, thank you for joining us. I'll turn this over to you to give us an overview of the data that we have available.
Thank you so much, Dr. Cruz. Thank you all for the invitation and the opportunity to present today. I will be sharing my screen. And hopefully you can see that. Okay, excellent. Again, thank you for the very warm introduction. My name is Nandini Selvam. I'm with IQVIA. I have about 15 slides, so I'm going to try and sort of whiz through it, and I look forward to taking questions from you. For those of you who are not familiar with IQVIA, we're a large Fortune 300 health services company that specializes in everything from clinical trials to data and data insights. Today, I'll be showing you some of the results around adult vaccination trends for a few key vaccines and some quick insights in terms of what we're seeing for some of the newly launched vaccines as well. And I will take you through what we see as far as certain sociodemographic characteristics as well. So before I launch into the actual results, I did want to take some time to provide context. As part of this work, we reviewed the impact of the COVID-19 pandemic on routine adult vaccinations. So really, that's the topic that I'll be talking about today. We specifically looked at influenza, pneumococcal, and shingles, but we also then took a look at maternal Tdap vaccinations. Our data sources were really so our administrative claims data. So we have individual patient level data that represents both the private sector in terms of commercial insurers and public sector as well, across all 50 states of the US. It's a fairly large study population that we start with. So thinking of secondary patient level data, we have the ability to look at very large swatches of the population. So we had roughly 260 million adults that were 18 plus. And once we started including the inclusion-exclusion criteria with the ability to track over time, it brought us down to about 60 million patients. And then we calculated vaccination rates based on the US population. So we were able to align it to the US. I know we have some key findings here, but I'm going to hold on it and first go through the individual vaccines, first provide a summary, and then you can see some of those results coming up. So here is a summary look. Very quick eyeballing tells you that these numbers aren't great. Across the board, the highest rates we have are for the influenza vaccines, and that's amongst the oldest age groups, right? 65 plus, where we see it cross about 62%. And even that peaked a couple years ago in the height of the pandemic. And then it's coming back down just a little bit. I wouldn't say it's necessarily a downward trend, not yet. The numbers are really close in terms of the last couple of seasons. This data actually ends as of June 2023. So in an effort to sort of hold for trends and keep it a little bit constant, we're behind by a quarter for these looks. And then we also looked at shingles vaccination rates. So looking at the 50 plus adults, we have about 9% of those that newly convert into this age group that are currently getting vaccinated. So this is not a cumulative number for all adults and their shingles vaccination status, but of those who are converting over during these years. Same goes for pneumococcal. Again, pretty low considering what you could be at. But there seems to be an increased trend, and that has a little bit to do with around the policy decisions around shared clinical decision-making going away. So you are seeing some increases in that. Tdap vaccinations, this also is somewhat of concern that only about half of pregnant women are really choosing to get their maternal vaccinations. So that's really what we're seeing across the board from a summary perspective. I know that's a lot of information, and what I'll do now is take you through each of these vaccines in some depth, and then we can go back and answer any questions that you might have. So what we've done here, and I'll orient you to the general slides that I'm going to have in the next few looks into the other vaccinations as well. So what we have here is the top left is vaccination rate by age group. So in looking at influenza, the trend is similar. So we looked at the summary slide where the highest numbers are really in the 65 plus adults. And then we also have the 50 to 64, the 18 to 49, and then you have the 18 plus, which is this dashed line in the middle. We have race. So this is very, very rudimentary if you think about it, right? Our race, ethnicity criteria are way more nuanced and complex than the way this is. But in the way it shows up in this data, what we are able to say is anybody who checks off the Hispanic button gets into the Hispanic, but otherwise they fall into Asian and others, white and Black. And what you're seeing here is really that amongst the trends, and this is pretty consistent across the vaccines as well, the lowest tends to be amongst the Black Americans, that followed by Hispanic, and then you have, depending on which one you're looking at, either the white or the Asians tend to be among the top in terms of consumers of these vaccines. By payer channel, what we're seeing is generally it's usually the private, but in this case, it actually doesn't really matter given how low cost this is. And what we're seeing is about 50-ish% among the public versus the private insurance payer channel. Urban-rural status, I would take with a grain of salt because some of this data is really small depending on the population. So I would say that these numbers kind of intermingle and they don't seem to be vastly different. So I'm going to leave this one alone for now. And finally, as one would expect, the highest socioeconomic status tends to be the most likely in terms of uptake. We also looked at it as year-over-year differences in terms of where this vaccination is happening by state to see if there's anything that's happening differently. What you're seeing on the left is the age group 18 plus for influenza, and on the right is 65 plus. And anywhere that's green is good. So essentially, there was some type of improvement over the prior year. Anywhere that you're seeing, and you can see this legend on the bottom, the darkest of reds is the worst off in terms of having gone down from the prior year in terms of vaccination status or the number of vaccinees in that particular geography. And then the greener it is, the better it is. There are obviously numbers within this, and we'll be sharing these slides as well, so you can take a deeper look into this. But the general thought is we don't have so much green. In fact, we're seeing some declines in some of the really super green areas. And then if you look at the 65 plus, it does give you the view that it's improving, but it really is, once you start stratifying it, it's not so equal. The next one is shingles. So this is something that's recommended for 50-plus-year-olds. These are not annual like the influenza vaccines. And when you look at the 50-plus age group, again, you'll see similar sorts of trends in terms of who's actually getting it. And pretty consistently, it tends to be, at least in the top areas, it tends to be amongst the older individuals. In this case, it's the 60 to 64. And then you're seeing a little bit lower among 65 plus, and then there's the 50 plus, which is the recommended age that's following in lower. What's interesting with shingles is that we are seeing improvements. It's across the board. You'll still see some lags with the different different race, ethnicity categories, but across the board, there are some improvements. Same goes for public-private. There was a switch on this one as well, and it has something to do with the way we're getting reimbursed, but they are converging. So they seem to be more or less, there seems to be similar sorts of outcomes in both of those payer channels. And then skipping over to income, again, very, very close, but the highest income, again, is on the top. Looking at, where are we on time? Okay, looking at year over year, again, in the 50-plus age group, we are seeing that there's improvements. This is also good because it seems like at least that when the recommendation and the advice shows up for them to get shingles vaccinations, it is happening earlier. And then for a variety of reasons, the 65-plus, it's not the same. As far as our data can tell, these are folks who don't have a vaccination in their record for the past 12 to 24 months, I believe. So it is possible that it's outside of this window, which is why there might be a little bit of a tail in terms of why this looks red. Pneumococcal shows very similar trends to the other vaccines as well. This is recommended for the 50 plus years for Pneumovax and then 65 plus for Prevnar. You'll see that there was a little bit of a dip. There's a little bit of supply chain issues as well from a couple of years ago. But then, so this view is for the 50 plus, and this one is for the 65 plus. So we were able to actually separate it out to say which ones, if there are different age groups and how they're responding to the same advice or recommendations. And similar to other things, 65 plus, the older age group seems to be much more compliant. And then when you look at the race, ethnicity, similar sorts of things where you see actually in this one, the lowest seems to be amongst the whites versus Black, and then you have Asian others, and then the Hispanic is the second highest. So we'd have to take a closer look to see what's sort of influencing this switch in race ethnicity for this specific vaccine. But it does seem to be a little bit different than the other ones, at least as far as race ethnicity is concerned. And then looking at household income, this is consistent with the other vaccines as well. Pneumococcal seems to be painting a much greener picture across the board. Part of that might be just improvements. It's also based on, I think there are opportunity costs in terms of promoting one vaccine over the other. And I believe pneumococcal was a beneficiary of that over this last year, but I'll let the other experts weigh in as well once we get into it. Tdap vaccination, I'll just say that looking at race ethnicity, again, it does look like, again, we have Black on the bottom, followed by Hispanic, and then the other two, white versus, and then Asian. So again, something that we can look for as part of education and getting out there, at least to these sectors. And we have most of the country, the parts that you see that are gray are ones that we don't have enough of a population to then make any sort of recommendations or provide insights into. So we've grayed those out and kept the rest of the states. I'm zooming through this so you can also take a look at some of the hottest off the press data. So what I have here is, in addition to the data that ended in June, I did have the team also pull it up by supply chain to look at the total RX volume for the new COVID vaccine and what we're seeing week over week. So this data will give us weekly data. It was updated through 10/20. We actually have another one for last Friday as well. It doesn't seem to have been updated in this view, but what you're seeing is roughly in millions on a weekly basis, how many individuals are getting the COVID vaccine. This view doesn't actually have a race, ethnicity, or any other individual profile against it. So that's why it's not presented. And then we can see the RSV vaccine. This data is in the thousands. So we're looking at about 500,000 individuals who got the RSV vaccine last week, about 600 the week before, 614,000 the week before that. So you can see how that looks like over time, and how we can continue to expect that to look like is sort of going to be based on what people do. Tdap, now this one has no seasonality. This is just purely what we're seeing. It's in the thousands also. It's against the number of pregnancies and doesn't necessarily have any type of a seasonal component to this. And my very last slide is on influenza, and it's the RX volume on that one. And so we've seen a peak sort of in the earlier part of October. We'll continue to collect this data, and it'll be telling in terms of how people are continuing to get vaccinated. I know I'm a little bit over time, so I'm going to stop and turn it over back to the team.
Thank you, Dr. Selvam. Interesting to see the how influenza vaccine has decreased across the country, right? That's very interesting, and it's very informative for those of us who are working in public health and communicating information to our populations. So very, very, very interesting. Thank you so much. And as we think about recommendations for broadening equitable access to vaccines that protect against infectious respiratory disease, it's actually compelling to see the real world implications of vaccine uptake. So thank you so much for your input. Next, I'd like to welcome our additional speakers, Karyne Jones, President and CEO of the National Caucus and Center on Black Aging, and Dr. Georges Benjamin, Executive Director of the American Public Health Association. And as President and CEO of NCBA, Karyne leads one of the country's oldest organizations dedicated to aging issues. Drawing from her experience working on Capitol Hill, as well as her tenure within the Texas legislature, Karyne brings to us a wealth of knowledge and expertise. In addition, we have Dr. Benjamin, who is board certified in internal medicine, in addition to being the head of the American Public Health Association. And he previously served as Secretary of the Maryland Department of Health and Mental Hygiene. Thank you both for being here with us today. We're looking forward to a robust conversation. And to get started, I'd like to ask each of you to share your thoughts on whether you think we are better prepared to protect ourselves this respiratory season. And I mean against the flu, RSV, COVID, and pneumonia. And, given the data that we just saw, what comes to mind? Why are we in the situation that we are? Love to hear your perspectives. Dr. Benjamin, if you can go first, and then we'll move on to Karyne.
Well, good afternoon, everyone. I'm very happy to be here. And at Cruz, this is fascinating. I really enjoyed seeing that data because that's exactly the same kind of data that we had back in the late 80s, early 90s with children's immunization, when we were basically in the high 60s, low 70s, depending on where you were in the country, and even some places in the 40s. And what we did was we had tools. We had the vaccine. So I think we're much better prepared in that we have the tools, but we haven't utilized them in a way to get everybody vaccinated.
That's right. Thank you. And yeah, we do have the tools, and I think sometimes the awareness is not getting to the communities that we need to educate and inform, right? So thank you for that. Karyne, what are your thoughts on this issue?
Well, again, thank you, Dr. Cruz. I'm very glad to be a part of this team. I tell you what we're seeing with our African-American older adults. Yes, the tools are in place, and it's just remarkable that we do have vaccines that can address these viruses. The problem we're having now that even we didn't have maybe so much last year is confusion. There's just so much. So, we were early on, of course, when the COVID vaccine was available, and we knew how disproportionately it affected communities of color. We worked extremely hard to try to change and to educate and deal with hesitancy and to really get access to the vaccine out into all the communities so that we could see a change. And we did begin to see that change. Then we were told that, you needed to get a booster. Then, of course, the season came around where we also encouraged our older adults to get pneumococcal. And now we've thrown in RSV, and they're just confused on when to get it, when to not. And you have to understand that everybody does not have access to one provider, one doctor. So they may be getting mixed information and misinformation from different sources. And so I don't think it's a lack of that we know that we have the vaccines available to address these, and we know that it would make an incredible difference in the health, particularly addressing where we already know people are coming from health inequity and health disparities. We know that it's there. It's in that confusion right now that we see with particularly our older adults on when, how, am I supposed to do these together? How far apart? And I think we have to do a better job of trying to explain that to the general public.
That's right. That's right. I couldn't agree with you more, Karyne, with regards to the confusion that we are seeing in the community with regards to the vaccines and at the digital divide, right? And a lot of the information that's accurate is primarily available through online mechanisms, and many members of our communities, unfortunately, are still experiencing that digital divide. So lots to look into, discern, and do there. And Karyne, while I have you there, I know you have communicated with the Centers for Disease Control and Prevention, and our NHCOA has also collaborated with you and other stakeholders on outreach to the CDC about vaccine policy reform, which could support closing the health equity gap, such as rethinking the age range for routine adult vaccine recommendations and reconsidering shared clinical decision-making. Can you talk about why you think these types of policy changes could help to support increased vaccine uptake within communities of color, underserved communities?
Well, we know that the vaccine policies have dramatically shifted since COVID. And we know that there have been population-wide vaccine recommendations that we hope would benefit. The issue that, of course, is concerning to us in dealing particularly, and I, of course, being with the National Caucus and Center on Black Aging, my focus is on older Americans who are of Black descent, is that they already come with a health and equity issue. And so if you're going to do the shared clinical decisions, it has to take into consideration that they're already coming a little different with different health issues that, you can't blanketly just say that you're going to put it up, it's got to start at 65 when we know for issues that we have in our community, it may require it to become at an earlier age. We know how that is in testing for cancer, for diabetes. I mean, all of the other diseases that affect heart disease, all of those things affect us earlier. And so when you do a blanketed thing, it's not a cookie cutter situation. That has to be taken under consideration. And I don't think that's always included in those decisions. I think the effort is there, and I think I have worked over the last few years with Healthy Women and with the Alliance for Aging Research. We are the co-conveners of the COVID Education and Equity Vaccine Program. I know they're going to kill me because I didn't get that name right. CB, which is the COVID Vaccine Education and Equity Project. There we go, where we have over 250 partners that have been working with us. And so it's important for us, we've gone beyond not just encouraging the COVID vaccine boosters, and of course, still addressing hesitancy, still addressing access, but we've also expanded that now to make sure that our communities have as much information and education and awareness on vaccines that are important to their health. So again, understanding that when you come out with shared decision-making, the only way we're going to see any real improvement in any patient experiences or any population experiences is that we've got to be able to increase the trust. We've got to be able to improve in the awareness of risk and benefits. And we've got to understand that every population, every community is not coming at the same rate because of health disparities and because of how health inequities have affected our community.
Right. So important to look at historically what our health has looked like as we look at vaccines, right? I mean, it informs the behavior when it comes to, getting vaccinated and how we look at the information. So, Dr. Benjamin, APHA is doing important work to help identify the barriers to vaccine equity among different populations and provide solutions for overcoming them, right? We now find ourselves over 3 years beyond the onset of the COVID-19 pandemic, yet we're facing what could be another year of serious respiratory threats, the flu, RSV, and pneumonia. Do you have any strategies you would recommend to overcome barriers to vaccination that have emerged or grown stronger?
Well, thank you for that question. There are 5 things I think we need to do. First of all, as we enhance the education that we have to do in our communities, number one, we need to make sure we understand the fact that many people don't even know what a vaccine is. We make the assumption that they do. And we really need to make sure that people understand what they are, what they're not, what they do and what they don't do, and their safety profile. Secondly, I think we need to work very hard to do that through trusted messengers. And that often means while physicians and nurses are often highly trusted by their patients, people do have mistrust with the healthcare system overall. And we have to address those historical areas in which people don't trust. And that means bringing in people, family members, that means educating people in the clergy. During COVID, we spent a lot of time with barbers and beauticians, and people that people go to all the time to get trusted information, but not necessarily the folks that you would think they're going to get trusted information from. It's because they trust them, they're friends, they talk to them all the time. And in many ways, we try to deal with those rumors so that we address misinformation and disinformation early in the process. We all think we need a new vaccine for adults program, very much like the Vaccine for Children's program, which is a comprehensive program which ensures an infrastructure to deliver vaccines, particularly for adults, to mirror the one we have in kids, as well as a program to address underinsured and uninsured people who need vaccines. Avoiding missed opportunities. When I mentioned earlier about the way we fixed the problem for children when the numbers were very low, there's an enormous number of missed opportunities where people come into a place sometimes wanting to get vaccinated, but for one reason or another, it doesn't happen. So identifying what those missed opportunities are. During COVID, we improved the number of places people get shots. We improved the way they got there by offering transportation opportunities to get there. We increased the number of vaccinators using EMTs, paramedics, pharmacists, giving them the authority to give vaccine. And we addressed the cost of these vaccines. And now that it's going back to the private sector, even though the Affordable Care Act allows it to be low cost, no cost, there's still challenges to getting that if you don't go to the right place to get your shot. And if you're uninsured and underinsured, you pay the full rack rate. So we need to, even though the federal government has their bridge program right now to address underinsured and uninsured Americans, after that goes away, we won't have a program. So we need to make sure we address that as part of that process. So those 5 things I think are very, very important as part of this process. And APHA is working to ensure that we have both the laws and the authority in place as well as the funding.
Right. I think the idea of having a program that looks at adults and vaccination like we do children is a very interesting one. I think it's something that we should pursue and collectively support that effort.
And there are some states that are rolling that out new. I know there's a limited one in Wisconsin, and I think there's maybe one in California. So states, as always, the places of laboratories of experimentation are trying to do this already.
Right. Well, that's something to look into and continue to monitor. Great idea. And I'm thinking about misinformation about vaccine science, vaccine hesitancy, and fatigue. What can be done to ensure those populations most at risk are taking the necessary steps to protect themselves? For you?
Well, I think Dr. Benjamin hit a lot of those in that, and overall, and what he said in those 5 things is that we have to be persistent in our education of letting people, as you get older, even before COVID, people probably didn't even really think about vaccines. It took us forever to get really people to understand that annually they would have to take their flu shot. And so they did start doing that as just part of their routine. They looked at it as a flu shot rather than a flu vaccine. And so, it may have been even in just the language that, it's going to protect me from getting the flu. But then when COVID came, and then again, now with all of the other things, of course, pneumococcal came on. And so they've seen the commercials and, they've learned about that, and they know people who have died, obviously, from pneumonia. So that had some uptake, not enough, but it did have some interest. Now we have COVID, we have RSV. Again, I just have to focus on just so much confusion, not maybe so much the unwillingness, though we do have to deal continually with hesitation and distrust. But I think it's also just the confusion of all of these different vaccines and the fear of, when do I take, how many, will they interact? Why can't one protect the other? These are all the questions that are coming up because they all understand that it's all respiratory in nature. And so, it's just so much confusion. So I know our organizations and other advocacy organizations working in the aging field are certainly working to try to address just dealing with that confusion and trying to educate them. And I think a nationwide vaccine program would be wonderful in that as we get older, we just hadn't really thought about vaccines until COVID. And so I think that's really important. Shingles, remember when people started thinking about shingles and, they were aware that they could get the possible, we saw just a little uptake. But again, it was a trust factor of, well, do I want to take it? And it really is all in how you said. People will go get a flu shot. They don't realize they're getting a vaccine. They don't understand. I mean, they finally, I think, got to understanding that the flu changes every year, so that's why they have to get an annual shot. But now they have to get used to the fact that COVID also changes, and that's why they maybe have to do new boosters. And so it continues to be an ongoing effort that we have to just work on making sure that people have the education so that they feel empowered. So when they do go for their care, whether they go to their own healthcare provider, doctor, clinic, or what have you, they have enough information to ask the questions and get them answered so that they feel comfortable in receiving these updated vaccines.
That's right. And education is power. And, I think it's important to continue to remember that as we communicate with diverse populations, we do it in a way, right, that is appropriate to their language, to their culture. And so I know those of us here at the webinar are very aware of that and intentional about that.
And you add something to that?
Absolutely,
yeah.
yes.
So I think action words really help, right? So in just speaking with different populations sometimes too, I don't think they understand necessarily the implications, like, okay, let's check that off, let's go get it done. So it's often a sense of responsibility, but it's really important to say like, hey, you can help protect if you're an older adult, sometimes they don't care about themselves. And I think if you cater to and lend itself to the community networks around them, more recently, I've talked about, like, well, don't you want to protect the children and grandchildren around you, because you can also be it really lends itself very well, even my own family, to get my dad out there really quickly to go get a shot. So I think we need to give some operational translations to what the impact could look like. And it's when dealing with minority populations, I think the crux of it often lies within the community aspect and the impact that they could have on the community, especially their family around them.
That's right.
We
Very
use that a lot during COVID, in that it's not just to protect you, but to protect the people that you love. And that used to get even young people saying, well, I better go get, because I don't want my grandmother to get sick. Or someone older would say, yeah, I'm the matriarch or I'm the patriarch in my family, so I'm going to make sure all my family members are protected. So that does work very well.
Yeah, absolutely. And I think women also have an important role in our families, right? I mean, we tend to look after the well-being of our siblings, of our parents, aunts and uncles. And so I think women are also important voices that we need to pay attention to, and we need to support, build those voices so that they can have sound messages across our families and across our communities. Let's look into chronic illnesses and vaccines. Given that CDC estimates show that 85% of individuals who are over the age of 65 and older have at least one chronic condition, and diverse populations have a higher prevalence of comorbidities than white populations. What can we be doing to help educate older adults on the risk of serious illnesses? Anything else that we should be doing for older adults who have comorbidities, diabetes and hypertension, and and the importance of this segment of our population to get vaccinated?
Yeah, I would argue clearly a lot more work with the primary care community. We need to make sure that every single person has a primary care practitioner, has a medical home of some kind, and the ability to track their medical records. And every visit when you go in, they need to ask and update about their vaccines. That ought to be, we always now ask about their well-being, about their state of mental health, about whether or not they're food insecure. We need to make sure that they also get asked about their vaccination on every single visit. And that just needs to be part of standard of care.
I think, too, that it's intergenerational, Dr. Cruz. I try to make sure that we certainly encourage our older adults to ask questions, because they're intimidated when they go in. I mean, the doctor knows everything. They're just there. So, they'll do whatever the doctor says, but don't be intimidated. Ask, and you will get an answer most of the time. And, if a doctor's seeing 50 patients a day, he's got a list. I'm going to check your blood pressure. I'm going to check and he's got a list, and he may not ask about the vaccine portion of it. So that's why it's important for us to empower our older adults to be able to ask the right questions. And I'm sure in every primary care physician will take care of that and remind them, oh yeah, you really should go get this, or that's very important for you to do. So it has to almost go two ways. The other thing, when I say intergenerational, I don't want people to wait until they're 60 to decide that, oh, I need to do this, when they've already probably been afflicted with a chronic disease. So we've got to make sure that we've given enough information to young people on what they have to do, so that as they age, or when they get to that older state, we can avoid some of these chronic diseases like high blood pressure, cholesterol, some of the other diseases that plague our communities. And so obviously access to quality health care in our communities is important to avoiding that. And if we put that all together, the cost of healthcare when you get older, when you've taken care of it when they're younger, it would be greatly reduced if we could really work on improving the quality of healthcare as you age. So.
Thank you, Karyne. Thank you for that. Dr. Selvam, do you, any comments?
Yeah, I was quickly going to say another thing that we struggle with is sometimes the timing of these vaccines. And so Karyne was just talking about going back to the provider. I think another way to do it, considering the high volume, high percentage of individuals who get their shots from the local Walgreens or CVS, so looking at retail outlets, another thing for providers themselves to do is when they see the patient, if there is a second or they have a shot that they'd like to space out and say, you know what, we've given you influenza and COVID today, but maybe RSV, you can do it. You know, it could just be that the patient's only got 2 arms, and it's not that it's not allowed to be co-administered, but if they make a decision like that, there might be a lower threshold, lower bar to having that accomplished if they actually just recommend they go to the nearer retail pharmacy where it's easier to make appointments, it's faster to get in and out, versus telling them come back to my clinic and it's now another 6, 7, 8 weeks later. So I think there are some important things that even providers can do to improve compliance.
Yeah, and let me just say one other thing. I think it needs to be noted that right now there's a shortage of some of these vaccines at various local pharmacies. The hours at some of these pharmacies has changed. And if somebody decides they're going to go and get one of these vaccines and they don't have it, you have to come back, you have to call. That's a deterrent for us then really achieving the goal of making sure that they get it. So we've got another problem that we can't address on this webinar, but the access to and the availability of these vaccines at various places that are accessible to people who mostly need them. That's a real problem across this country right now.
Yeah, and Karyne, I know we in the past have talked about the importance of having trusted messengers delivering this, health-related information, vaccine-related messages. Any ideas on who should we be thinking? I know Dr. Benjamin talked about religious leaders. Who else should we be keeping in mind as we look at leaders in our communities to help us get the word out?
Well, in the Black community, we love ministers and we trust our ministers. We trust our barbers. We trust our hairstyle. I mean, the people within our community that we know care about us. And so I think every community is different. I do think, it's just like politics is local. Well, information sharing and trusted leaders are also local. And that's why we work really hard to, when I'm part of a webinar, I try to make sure that if we're specifically going to a particular region or a city that we're addressing, I try to make sure that there are people from that community speaking, because some woman from Washington, D.C. coming in and telling me I'm fine, but they would trust someone so much more who was a local community leader that they knew, that they've seen, that they've gone to church with, that they see at the grocery store. That's the person that has to get the message. And we've got trusted leaders all over the place. We just have to empower them and give them the information so that we can have a broader range of people understanding why these vaccines are so important.
That's right. That's right. Any thoughts, Dr. Benjamin, on that?
I think that just not to beat a dead horse, as they say, the more we engage our community, the more we engage people that folks have to deal with each and every day, empower them with the knowledge so that they don't get the information off of an untrusted source, the more effective we will be.
Yeah, and a question came in just a few minutes ago. And I think this question is geared to Dr. Benjamin. A pediatrician is asking about any practices being done to address barriers, like small practices being able to afford the minimum order amounts for vaccines. And then that there's also no mechanism for referring their patients to another provider. Any thoughts on that?
Yeah, that's a significant issue, and I think that's kind of in the ballpark of the the professional societies, particularly at the state level, because there are two parts of this. Number one, the challenge is if you have a small practice and you only need 20 doses. The problem is the vaccine, at least the COVID vaccine, came in 1,000 dose blocks, and you didn't need that many. The other problem you had with the COVID vaccine was in many cases, at least early on, it required ultra cold storage. So there are efforts now to do from the pharmaceutical companies to do smaller packaging, to change the formulation so it doesn't require the ultra cold storage. Some of the newer vaccines do not. But the issue of the infrastructure around small practices, the medical groups need to reap those practices into a co-op to allow them to be able to share resources so that they don't have wastage, because they have to buy it out front and then they don't use it. It's wasted, which is a loss of a valuable commodity, and it's a fiscal loss to them. The other thing I do think is that we need to find ways to subsidize them on the payment side, so that they have an additional kicker in what they get when they're going to encourage them to vaccinate people, particularly in rural communities, again, where you have low volume, just like we do at rural hospitals, provide financial incentives and supports for those smaller practices to allow them to be able to, frankly, afford to stay in the business, understanding that's a public good. And that's a policy issue that I think HHS, HRSA, CDC, through those vehicles need to work with the medical associations in those societies to do that. So American Academy of Pediatrics, American College of Physicians, American College of Family Physicians, the nurse practitioner associations, those groups can incentivize and work with the federal government to make sure that happens through advocacy.
Thank you, Dr. Benjamin. Here's another question. How can vaccine advocates help to address some of the barriers raised today to improve vaccine uptake in our communities?
Yeah, let me start with one. I'm gonna push on my Vaccine for Adults program again. The Biden administration actually put that out as a budget proposal and as a policy proposal. So I encourage everybody first to become familiar with that and to talk to their local members of Congress and senators and representatives, so that we can actually get that passed in this budget year.
Yeah,
because there's money in there for the infrastructure.
Terrific.
Mhm.
Dr. Selvam, any comments?
No, I think we've talked about sort of the various ways already. I don't have anything additional to add to that. Thank you.
All right. And just lastly, I'd like to just go around and see if there's any other thought, recommendation you'd like to share today before we conclude. So, Dr. Benjamin, anything?
Yeah, I encourage people to just make sure they spend some time understanding who the trusted messengers are that they want to trust, and then trust them, and be skeptical when you hear something that doesn't sound like it makes a lot of sense. It probably doesn't make a lot of sense, and validate when you get crazy rumors before you pass them around.
Very important. And God knows we're getting a lot of those rumors around. Thank you. Karyne?
I think I think about early on, particularly with the vaccine, COVID vaccine, and all of the misinformation that was out about that. But I'm pleased that then finally we were able to overcome some of it. There's still a lot of people that aren't vaccinated, but we saw a drop in the deaths and people getting sick. We've forgotten very quickly that 1 million people died as a result of that virus. And, we stopped seeing the numbers every day increase on our television screen, and I think it went out of our head. There are still, they say 500 to 700 people a day still dying from COVID. So it is still something that we have to, there's still too many people. And so that is still something that we have to work on and continue to try to work within each community as much as we can to get information out, and really rethinking some of these age decisions that come out when trying to develop these, because again, in communities like mine, 65 might be too old. I mean, be too late. There may be people much younger. And then, as Dr. Benjamin mentioned, the fact that a lot of these vaccines are not going to be covered. And if you're uninsured, you're too young for Medicare, you're not eligible for Medicaid, you're put into a real bind, and then therefore you're still susceptible to getting these illnesses. So there's still a lot of work we have to do to try to educate people and try to make sure that it's still equitable in terms and access is available to people so that we can see a real positive outcome of a healthier society.
Terrific. Dr. Selvam?
Yeah, so thank you again for the opportunity today. But I want to sort of piggyback off of Karyne and Dr. Benjamin's points, right? So in terms of us being community advocates, so in thinking about what can we do to simplify, I think simplifying the message helps a lot. I tend to be visual personally, so I think of it this way. So if you have your community of barbers and clergy and others, isn't there an amazing opportunity for us to even create just a single page that we can hand out that they can plaster on their walls? Whether it's to, so there is a separate issue around lowering the age bar, but for the age that we have right now, wouldn't it be amazing if we could get out something that people can see and say, oh, you know what, I already did this, or here are the 3 things I need to do. How about we help simplify that message a little bit more? And I do think that helps build one, force multipliers. So not only are we putting it out there, but then the folks that we're hoping to be those community leaders and supporters throughout this process also have a really simple way of articulating it.
Terrific. Well, I think your comments about how we shouldn't forget that so many people died as a result of the pandemic, and that we should continue to use that as a point of reference for our work. For Hispanics, for example, COVID became the leading cause of death, taking over cardiovascular disease, which was #1 for years. So I think it's important for us to not forget that COVID is a huge problem, and that we do, and that vaccines is one important mechanism to prevent illness and death. So with that, I wanted to thank all of you for joining us, to our wonderful panelists for making time to be here. We invite our audience to continue to follow our work. We'll remain connected, and thank you again, and enjoy the rest of your day.
Thank you.